blurring this, we end up thinning down this calcification significantly, and that allows the following, which is to thin the calcium and finally to induce calcium fracture, which allows stent expansion. Now, it's important to understand wire bias lesion preparation. Here, for example, you can see calcium fracture being performed. Now, here's this wire bias dependent lesion preparation that I wanted to talk to you about. You can see, you can see the tram tracking of calcification on this angiogram in front of you. But what you'll of course imagine is that if you take an imaginary track of the path of the wire will bias on the inside of this calcium nodule and very heavily gutter towards in this tortuous vessel. And this can be problematic because not understanding the wire bias can lead to this situation, which is basically cutting the atherectomy directly into the tissue and after stenting leading to contained perforation. Now, what about nodular calcification? In nodular calcification, it's really important to understand the wire bias. Again, here's an example of a patient who has rotational atherectomy. You can see that the OCT catheter is not biasing against the nodule. And after atherectomy and before atherectomy, there is literally no impact whatsoever. Inadequate vessel preparation. And now you'll be able to see why. Because the calcium nodule is on the outside of the artery, but the rotablation burr is on the inside of the artery. And as a result, we do not get any debulking. Here in this example, when we then perform rotational atherectomy, so with orbital atherectomy, you see that by placing the orbital atherectomy, we eliminate this wire bias and allow cutting into this nodule, thinning it down to the point at which we're actually able to impact it. So this imaging completely guided the lesion preparation. Thus, I would strongly suggest that we consider to use an algorithmic approach using advanced OCT imaging for advanced calcium lesion preparation. So in summary, angiographic severe calcification leads to stent under expansion and is associated with high TVF rates. In the presence of angiographic severe calcification and perhaps even moderate to severe calcification, using an algorithmic approach using intravascular imaging could optimize therapy. The device choice is dependent on imaging findings. Imaging should be studied to optimize device selection, and calcium fracture should be identified prior to DES deployment. Thank you very much.
Thank you, Dr. Ziad, for your excellent lecture. Now I refer it to Dr. Hiramat to call our friend Dr. Ashok Sheth. I would request Dr. Ziad to be with us for the next few minutes to moderate the session. Thank you.
So it's my
Dr.
pleasure
Hiramat,
to invite Dr. Ashok Sheth. Ashok, I'm sure you don't need introduction, but he's been a driving force behind many cardiologists across the globe. And whatever he shows in his cath lab and he's going to show you today is probably going to be a big learning for many of us. Ashok, stage is yours.
Ashok sir, I have sent a request to unmute. Kindly unmute, sir.
Yeah.
Ashok sir.
I think in the meantime, is it okay to ask a question to Ziad?
Of course.
Hey Ziad, this is Ramesh. Very nice talk, fantastic as always. And just wanted to ask you, in real world practice, I don't actually get the results of laser as I would love to. Somehow the laser results are not suboptimal for my practice, at least in my opinion. And any highlights on, have you seen that similar as compared to atherectomy? And sometimes we have to do this razor, which is a rotor with the laser. So, I mean, I think whenever you have to use another device on top of laser, that is a failure of laser. Can you please highlight on where
Sure.
you find it, especially in calcified lesions?
So first, since we can speak openly amongst friends, so I think that laser for utility for debulking of neointimal hyperplasia is a complete load of hooey, is the better way to say it. Or Gary would say it even better. What would Gary call it? It's just total nonsense. There is no evidence to suggest that does the case. And remember, the laser basically emits perpendicular to one side of the catheter. So it's not ever impacting 360 degrees of the artery wall. So first of all, for this debulking of neointimal hyperplasia, it's nonsense. For calcification, the amount of energy that's emitted by the laser itself without the addition of a cavitation bubble made by either saline or calcium is very, very small. And so what you need to have laser to be effective is you actually need a lot of luck, because you need the laser to take the wire bias and have the laser perpendicular to the maximum amount or minimum amount actually of calcification in order for it to be able to facilitate the calcium fracture. I've never seen it happen without infusion of either saline or with contrast. When you infuse contrast and you create a cavitation bubble, which is very similar to what happens in the shockwave device, you can create energies which are very similar, about 50 millimeters of mercury. The difference, of course, in the shockwave is it's controlled in the balloon, and in the laser, it's completely uncontrolled. So that's my take on laser, that if you're going to do it, you really have to do it with contrast or saline to facilitate cavitation bubbles. And as a result of its tremendously unpredictable nature, that would really only should be done inside a stent and not in a native vessel. Now that lithotripsy is approved in the US, I think the utility of laser for those situations will be become markedly diminished even further.
So, Ramesh, I would request you to introduce Dr. Greg Stone, because I think Ashok is not being able to connect. So, till the glitches are over, let us go, because it's almost 7 o'clock, because we are running over the time. So, Dr. Greg Stone is connected, I think. So, please introduce Dr. Greg Stone, Ramesh. And I thank, yeah.
Yeah, thank you very much, Dr. Kahali. And, as everybody knows, Dr. Greg Stone does not require any introduction. He has been with us on several occasions in India. He's the Director of Academic Affairs at Mount Sinai Heart Health System, Professor of Medicine, and he's the Professor of Population Health Sciences and Policy for the Zena and Michael Weiner Cardiovascular Institute at Icahn School of Medicine at Mount Sinai. And he has been the founder of Cardiovascular Research Foundation and has visited many times to India. And thanks, Greg, for taking on this talk on left main disease and Excel results.
Great, thank you. It's great to be here. Hi, everybody. Let me share my screen. Okay, so you should be able to see my screen now.
Yes, we can see it, Greg. Thank you.
Great. So I'm going to take a slightly different tack than just describing the Excel results, which probably most of you are familiar with now. I'm going to actually go from Excel to patient recommendations and how to actually integrate this data. And I have no specific disclosures with any stent manufacturer. I'm sorry. Hold on one second. I somehow have this on timings. I'm going to get rid of that so we don't get annoyed. Okay.
Thank you.
So this was the Excel trial. And as you know, we took 2,905 patients with unprotected left main disease. We screened for the patients that had a syntax score of less than or equal to 32, in whom there was consensus agreement by the surgeon that he could operate and by the interventionalist that he or she could get a good revascularization result. So there were very few exclusion criteria in this trial other than that and acute myocardial infarction. And we took 1,905 such patients and randomized them 1-to-1 to either PCI with a contemporary drug-eluting stent, that's Xience, versus bypass surgery. And we followed 1,000 patients who either were too sick for surgery or too high risk for PCI or had a high syntax score in an enrollment registry. And we followed patients through 5 years with the primary endpoint being death, MI, or stroke measured at a median 3-year follow-up. So this is the largest trial to date of PCI versus CABG in left main disease, and the first such trial to be powered for the composite endpoint of death, MI, or stroke without repeat revascularization in it, which all the surgeons and interventionalists that put the Excel trial together agreed was an endpoint of much lesser importance. And I'll come back to that. And this was the primary endpoint of Excel. You could see that at the end of 3 years, there was a 15% rate after CABG and a 15% rate after PCI. The difference was 0.7%. This was the upper 97.5% confidence limit. This was powered for non-inferiority. The p-value was 0.02, meaning that we met non-inferiority. That's it. That's what the trial is powered to show, that at the end of 3 years, there was no significant difference within our assumed margins of PCI versus CABG. Now, we followed the patients out for 5 years, and this is the overall results at 5 years. And again, this is an hypothesis generating endpoint. We had no power analysis and no hypothesis at 5 years. You could see an event rate of 22 versus 19.2. You could see the odds ratio of 1.19. The exploratory p-value was not significant. But you'll also note in this curve, very importantly, that the curves cross. You can see initially that there clearly was a greater hazard for bypass surgery compared to PCI. PCI was a safer procedure. But then the curves crossed so that at about 3 years, there was a catch up and they continued to diverge. So at 5 years, there was this slightly numerical advantage for CABG compared to PCI, but not statistically significantly different. Although again, you can see the confidence intervals are relatively wide and this was not a powered endpoint. So how do you interpret data when there are crossing curves? This is what we call non-proportional hazards. There's a period where clearly PCI patients do better and another period where CABG patients do better. Well, the first thing we can do is do what's called a piecewise analysis, and we can look for within the data when the proportional hazards are actually met. And you can actually see there were 3 different periods. Within 1 month is when there clearly was a less of a risk with PCI compared to CABG. And there was almost a 60% reduction in the hazard ratio with PCI and CABG of death, MI, or stroke. From 1 month to 1 year, interestingly, the restenosis period, there was no significant difference between PCI and CABG. Curves were superimposable. And then it was really between 1 year and 5 years where the curves start diverging and continue to diverge for with PCI being higher than CABG. And here you see a 60% increase. So if you're a patient, which is better? If you're going to have an adverse event, you'd rather have it later than sooner, right? Because you're exposed to the life implications of that adverse event from a later time period. But how do you overall make sense of this? Well, you can look at something called the restricted mean survival time analysis, which basically calculates the overall amount of time being free from an event. And when